All right, how we doing, folks? Welcome back to the next episode of Pathagonia. So I start surgical pathology again in a couple weeks. So the next couple weeks of episodes are going to be focusing on my weaknesses. So as a second-year resident, obviously I have not mastered everything in pathology. I've learned a lot of things. I've become a lot more comfortable with certain things in my first year of residency, but uh, you'll quickly learn in pathology that it's almost never ending, right? We can always study more, learn more, and get better. So today I want to focus on liver tumors. And again, this is from Kurt's notes. So I'll put a link to his website in the comments. And there are three sections from this PDF from Kurt's notes, and it's hepatocellular lesions, biliary lesions, and vascular lesions. So let's just dive right in. So we'll start with hepatocellular lesions. So all of the lesions for hepatocellular lesions are going to stain with hepatocellular stains, which are going to be Hepar1 and arginase. Also, there can be canalicular staining with CD10 and PCEA, as well as cytoplasmic TTF1 and surprisingly negative for MOC31. So we're all familiar with MOC31 as a stain that can commonly be used for adenocarcinoma and differentiating between adenocarcinoma and mesothelial processes, right? So surprisingly, hepatocellular lesions are negative for MOC31. All right, first up we've got macro-regenerative nodules. This is an unusually large regenerative nodule, often over 1 centimeter, that develops in the setting of cirrhosis. So you're going to see that as a theme, right? Cirrhosis being an underlying pathology and a lot of other things that can pop up in the liver, such as hepatocellular carcinoma and other processes that can develop if someone is diagnosed with cirrhosis. So in a macro-regenerative nodule, you can have hyperplastic liver parenchyma, and the plates may be slightly thickened, usually 1 to 2 cells thick, but maybe focally 3 cells thick. And you're going to have normal constituents, so you have bile ducts, arteries, veins, etc., but no atypia, and unless it's dysplastic, of course. All right, next up we've got focal nodular hyperplasia. So this is not a true neoplasm. You can think of it more as focal cirrhosis with regenerative hyperplastic response of the hepatocytes secondary to vascular abnormalities, and very common. And grossly, you can see this central stellate scar, which that could pop up in the gross room, of course, more importantly, or you could see it on a test or something like that. But you're going to have this well circumscribed process with a central stellate scar with fibrous septae, with entrapped vessels, bile ducts, and inflammatory cells. There's normal plate thickness, no true portal tracts, and you're going to have map-like staining with glutamine synthetase, which is what is shown in the image down here. So you have this map-like staining of glutamine synthetase, and on the left you see normal pericentral staining, and then on the right the strong map-like staining of FNH. Moving on, we've got hepatocellular adenoma. So hepatocellular adenoma is a benign liver neoplasm, often associated with oral contraceptives or steroids, and there is a risk of transformation to hepatocellular carcinoma and or bleeding or rupture. So histologically, you're going to see benign appearing hepatocytes with no significant atypia, normal plate thickness, which we're all familiar as 1 to 2 cells thick, and often you'll see these unpaired arteries with absence of the bile ducts and no mitoses. So no mitoses, that kind of tracks with this being a benign process, right? Mitoses you would normally associate with a malignant process or neoplasm, something that's proliferating and not acting in a benign fashion. And I'm not going to go over all of these, but there are numerous subtypes for hepatocellular adenoma. So at your leisure, be sure to reference those and their associated staining patterns and various molecular associations. And then again, just to reference the image, we have our unpaired arteries that can clue you in that this could be hepatocellular adenoma, and then our benign appearing hepatocytes. And then on the right over here, you can contrast this with normal liver. So we have normal liver and then hepatocellular adenoma. All right, a few more hepatocellular lesions. So we have hepatocellular carcinoma. So this is a malignant tumor with hepatocellular differentiation, and it often occurs in the setting of cirrhosis, like we talked about, right? If the liver is already damaged, then it could potentially lead to the development of malignancy. Hopefully not, but it is more likely if the liver is already damaged from other sources. And cirrhosis, so it often occurs in the setting of cirrhosis it's associated with chronic liver damage, such as viral hepatitis from alcohol and NASH, or non-alcoholic steatohepatitis. The diagnosis is often made clinically, so it's pretty amazing what radiology can do. So radiology, like certain radiological findings, plus an elevated AFP, is pretty supportive of the fact that it's going to be hepatocellular carcinoma. However, of course, if we're able to get some tissue in a biopsy or a resection, you're going to be able to prove definitively when we look at the cells if it is in fact hepatocellular carcinoma. And this can often be treated with embolization, resection, or transplant. So what are we going to see microscopically for hepatocellular carcinoma? You're going to see widening of the hepatic plates, so more than 2 cells thick, absence of the portal tracts, and often those unpaired arteries like we saw in hepatocellular adenoma. So the architecture in cytologic atypia varies and includes pseudoacini, pseudogland formation, and wide trabeculae. And there's often bile production by tumor cells, so you may see some bile when you look under the microscope. So IHC can certainly be helpful when you're working up a hepatocellular carcinoma. So what IHCs could we get? You could get a reticulin that would show widening of the hepatic plates. You could also get a CD34 that could have diffuse to sinusoidal capillarization, which is what we're seeing here, the CD34, which we know stains endothelial cells, but you would see this pattern in an hepatocellular carcinoma, unlike in benign hepatic tissue. And then also another stain besides reticulin and CD34 that's helpful is a glypican-3. So this could be plus minus, so it may or may not stain, but glypican-3 most certainly will be negative in benign liver. So if you do have some cells or a lot of cells that are picking up glypican-3, that can be strongly supportive of malignant process. And again, I'm not going to go over all of the variants, but I guess I will mention fibrolamellar hepatocellular carcinoma, because that seems to pop up often on tests or just in discussion of liver neoplasms. So fibrolamellar HCC often occurs in young, non-cirrhotic patients, and you'll have a normal alpha fetal protein level, and it's often a large solitary lesion. So microscopically, you're going to see large oncocytic tumor cells with bands of lamellar fibrosis, like we're seeing here, with cytoplasmic pale bodies and recurrent DNAJB1 PRK ACA translocation. So a fibrolamellar HCC can stain with CD68 and CK7. It's classically thought to be a better prognosis, but this is most likely due to demographics. So younger, non-cirrhotic patients having this, that would make sense that perhaps they would have a better outcome than someone that's older and cirrhotic that may develop just a classic HCC, right? And then of course, just review these other variants of HCC on your own. Next up, we've got hepatoblastoma. So hepatoblastoma is the most common liver tumor in children, and it's a malignant process, and it's associated with Beckwith-Weidman syndrome. It shows a variety of epithelial and mesenchymal cell types, recapitulating hepatic ontogenesis. So some of these epithelial types of hepatoblastoma are shown in the image. So we have our embryonal pattern on the left, then on the right we see our fetal pattern. And there's a frequent beta-catenin mutation with nuclear localization by IHC, leading to a worse prognosis. Moving on, we've got biliary lesions. So for biliary lesions, the epithelium in all of these lesions stain with CK7, CK19, and MOC31, among other stains. These lesions are negative for the hepatocellular stains like Hepar1, arginase, and glypican-3. Right, so if you're trying to rule out is this a biliary process or hepatocellular in origin, if you get those hepatocellular stains and they're negative, that's pretty supportive that you could be dealing with a biliary process. So similar to the hepatocellular, we'll start with a benign entity. So in a biliary lesion, a benign process is a bile duct adenoma, which is a benign bile duct proliferation, usually less than 1 centimeter, subcapsular, and well circumscribed. So you'll usually see small, uniform small ducts with cuboidal cells and regular nuclei. And a variant of this, you can have a biliary adenofibroma, which has more complex epithelial growth with abundant fibroblastic stromal components. I'm actually working on a case report right now of a biliary adenofibroma that transformed into a cholangiocarcinoma, which is an entity that we'll get to next, which is rare, but obviously is possible. Moving on, we've got bile duct hamartoma. We actually just had one of these in my program that came up last week. So I just saw it in a conference earlier this week. One of my friends presented it. So bile duct hamartoma, also known as von Meyenberg complex, is benign, and they may be multiple and they're usually small. Irregular to round bile dilated ducts associated with fibrous or hyalinized stroma. And the lumens contain bile and proteinaceous material often. Next up, we've got cholangiocarcinoma. So cholangiocarcinoma is an adenocarcinoma arising from the intrahepatic bile ducts. So think of it as like a bile duct adenoma or proliferation of those bile ducts, but a malignant process instead of benign. So inflammatory disorders can predispose to cholangiocarcinoma, such as PSC, or primary sclerosing cholangitis, or a liver fluke infection. So you must clinically distinguish from a metastasis as overlap. Cholangiocarcinoma usually is a tubular pattern and sometimes has large ducts. There's often a sclerotic center, and it has a non-specific IHC profile, but positive albumin-ish supports intrahepatic. And there also is an entity of combined hepatocellular cholangiocarcinoma. So this is going to be shown here on the right. Up top left, we have just cholangiocarcinoma, malignant bile duct proliferation. And then on the right, we have combined hepatocellular cholangiocarcinoma, a single tumor with morphologically distinct areas of HCC, so arginase and Hepar positive for the HCC aspect, and then cholangiocarcinoma as well, which would stain with CK7. And CK7 is going to be lighting up those bile ducts, right? So if you want to see in another process that the bile ducts have dropped out, you can use a CK7, and if you see less staining, then you have pretty good proof that there's less bile ducts. But anyway, this is treated and the prognosis is similar to a cholangiocarcinoma. It's worse than just an HCC, and there's no transplantation if a patient has this. So some additional diagnoses to consider: you can have an intraductal papillary neoplasm, similar to an IPMN in the pancreatic duct, can progress to cholangiocarcinoma. You also can have a mucinous cystic neoplasm, just like in the pancreas. And just like in the pancreas, you're going to have that ovarian-type stroma surrounding mucinous epithelium. Next up, we got vascular lesions. So for vascular lesions, it would make sense, but all of these lesions stain with endothelial markers, including CD31, ERG, and FLI1. And that makes sense, right? So vessels are going to be lined by endothelial cells, so vascular lesions are going to light up with CD31, ERG, and FLI1. Cavernous hemangioma, first up, and it's appropriate that it's first up because it's the most common benign tumor of the liver. It's thought to be malformations and non-neoplastic, and it's often asymptomatic and diagnosed radiographically. So cavernous hemangioma is more common in females, with fibrous septae lined by single layer for flat endothelial cells, and they can thrombose and calcify. So hemangioma, you throw the slide down and you see these big dilated vascular spaces. That should be something that comes to your mind pretty quickly when you're looking at the liver, and because again, this is the most common benign tumor. So good news for the patient, it's benign, and good news for us, easy diagnosis, right? Next up, we've got epithelioid hemangioendothelioma. So this is an endothelial tumor of low-grade malignancy. You're going to have eosinophilic, slightly epithelioid cells with signet ring-like features representing intracytoplasmic lumina, often containing red blood cells. You're going to have an associated dense fibrous stroma that we see in the background, often have intravascular papillary growth and infiltrate sinusoidal spaces at edge of lesion. So the translocation for epithelioid hemangioendothelioma is WWTR1 CAM-TA1 fusion. And sometimes these can be focally positive for cytokeratins by IHC. But I've definitely seen this come up on tests, so something to definitely be aware of. Angiosarcoma is next up. So we've got a malignant endothelial tumor, and it's the most common liver sarcoma with spindled to epithelioid cells. There's variably atypical endothelial cells with multi-layering and mitoses, and anastomosing spaces. So angiosarcomas like to grow along pre-existing vascular spaces, and they're usually large and or multifocal. They're associated with exposure to vinyl chloride or thorathrast, and angiosarcomas unfortunately have a very poor prognosis, likely due to their involvement of vessels, right? So some other tumors to consider, you have a PEComa or angiomyolipoma, which is benign tumors, just like in the kidney where we have an angiomyolipoma. And think of this process if you see fat, and you're going to typically see a variable admixture of fat, smooth muscle, and thick-walled vessels, just as the name would suggest, right? Angio, myo, lipoma. So angio, thick-walled blood vessels, myo, smooth muscle, lipoma, admixture of fat. And this is angiomyolipoma is associated with tuberous sclerosis, usually asymptomatic, and is going to stain with HMB45 and plus minus for melon A. And the last but not least, we've got embryonal sarcoma. So this is a malignant tumor composed of undifferentiated mesenchymal cells, with usually older children is where this occurs. It's going to be a loose myxoid tissue with immature and giant cells, with characteristic eosinophilic intracellular hyaline globules. And these can rupture, and previously a bad prognosis, but it's improving like a lot of things in medicine, right? So that's it. That's all I've got for liver tumors. So in closing, I just wanted to show you Kurt's Notes, the website that I've been using by Dr. Kurt Schauberg. So if you go to the website that I'm going to link, what I like to do, I go to his page for diagnostic guides, which I'm on, and you just scroll down, right? So you've got the GI tract, inflammatory processes, tumors, liver, bile duct, gallbladder, and pancreas. And he has all these notes beautifully organized, great PDFs with great images, with very high yield, concise ways to learn and review this information. So I already went through the cytology section and made videos from all of these, which you can find on our page, Pathagonia. We have a playlist that we started for Kurt's Notes, and just now I did the liver tumors, and next up I think I'm going to do medical liver, and then I'm not 100% sure where I'm going to go. Maybe some more GI, or if I'm focusing on things I'm really struggling with, I may work on breast and GYN before my next surge path rotation. But yeah, I really encourage you to check out his website. He's got all kinds of good material. There's different links, articles, books, different reporting, diagnoses, and comments that he has saved. So Just an excellent free resource. Can't encourage you enough to check it out. I know it's helping me a lot as a second year, and I'm excited to keep working my way through all of these diagnostic guides. My goal is to get through all of them in the coming months. So I hope you are enjoying the videos, and I hope you check out Kurt's notes. Like and subscribe, and have a good rest of your day. Thanks.